I'm now intrigued by our third speaker, Dr. Nadia Sutton, who is going to kind of take on optimal medical therapy with current best therapy works extremely well. Dr. Sutton is assistant professor of the Department of Internal Medicine, Division of Cardiology and Interventional Cardiology at Vanderbilt University. She was previously at University of Michigan. She also has an appointment in the Department of Biomedical Engineering at Vanderbilt University, where she holds an assistant professorship. She's fantastic on so many levels, and we've had a wonderful, wonderful time working with her in the CLIMB programs at Women as One, but all of her work is tremendously important, and especially today, dealing with these two guys. Optimal medical therapy with current best therapies works well. Dr. Sutton.
All right, thank you so much. Full disclosure, I actually missed the memo that we were talking about LV dysfunction. So by default, you are lucky you won that part of it. So I'll just go ahead with my talk, which was generally about optimal medical therapy with current best therapies works well for the discussion of a patient with stable ischemic heart disease and consideration of revascularization. So let's see. Where's my forward clicker here? There we go. Okay, so I probably could have done this with 3 slides because I think that there's really just 3 major questions. So the first one being, what is optimal medical therapy with current best practices? Who are we talking about? And it works well for what endpoint? Okay. All right, so what is optimal medical therapy? And so I wanted to kind of take a little bit of a historical perspective. When you look back at the trials that have been done in this domain, first looking at RITA 2 starting in 1997, angioplasty versus medical therapy, to 2007, Courage, Orbita in 2017, and ischemia in 2020. And certainly there are other trials that I could have included here. The slide was getting a little bit busy. But really what we're talking about is how has optimal medical therapy evolved over time? Because I think a lot of times we're kind of talking about, okay, well, all of the trials have shown that medical therapy works well compared to revascularization for patients with stable ischemic heart disease. But when you actually delve into it in more detail, you'll see that actually what I think has happened is that over time our medical therapy has improved, as is our ability to revascularize patients in better ways. So when we look back and I'm sorry, this went back. So when we look back in 1997, we're talking about aspirin. Patients were not necessarily receiving statins routinely. Patients were getting anti-anginals, beta blockers, calcium channel blockers. You go on to 2007 and Courage, we're now adding on statins to our medical therapy. We're also talking about adding other medications to raise HDL. Patients were routinely getting lisinopril or losartan. On to 2017, patients are now getting DAPT with Orbita, and then with ischemia, you can see I actually had to move down that bottom arrow because the list of optimal medical therapy was so long for ischemia. The patients were really getting a very sort of overarching approach to their cardiovascular care. So with aspirin, P2Y12 inhibitors, ACE and ARB if they had hypertension or low EF, diabetes. They're getting a beta blocker if they've had a prior MI or EF less than 40%. Potentially, if they were in the US or Canada or Germany or Spain, patients were also getting Repatha if their LDL was not at goal. They were getting intensive smoking cessation counseling, exercise, encouraging them to actually exercise at least 5 days a week for at least 30 minutes, trying to get their blood pressure to a specific goal, getting the LDL to a specific goal, and then also getting the patient's BMI down as well as their A1C. And over that same time period, you can see that we were starting in 1997 with mostly angioplasty in the RITA 2 trial, and then in Courage, the patients were, towards the end of the trial, some of the patients got drug-eluting stents, but most of them did not get drug-eluting stents. In Orbita in 2017, and then in ischemia, finally we're having patients receiving second-generation drug-eluting stents. So again, just sort of emphasizing that while our medical therapy has improved over time, so has our ability to revascularize patients. And who are we really talking about? So as you can see, I have not included the inclusion criteria for these trials. These are generally patients with stable ischemic heart disease, but we are excluding a lot of patients from these trials. So we're excluding, in ischemia, patients who have a low GFR, patients with recent ACS. If there's unprotected left main disease in all the trials, that was excluded. If the patient had a low ejection fraction, less than 35%, if they had heart failure or unacceptable angina. And so at the end of this presentation, you might wonder which side I'm on, but I think that it is important to know exactly what these studies were actually including in the patient populations, because it's very relevant to what we take from the studies. And so what are the endpoints that we really are studying? So what does medical therapy work well for? So in RETA 2, we're talking about the combined frequency of death from all causes and definite not fatal MI. Courage, we're looking at death, again, from any cause or non-fatal MI. Orbita was looking at more of an exercise time increment, and then for ischemia, composite of death from cardiovascular causes, MI, or hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. And it is important to remember that in ischemia, the endpoint was actually triggered by slow recruitment and lower than expected event rates. It was originally going to be cardiovascular death and MI. So when we're talking about the results from these studies, it is important to remember that, we're, first of all, we are defining the patient's anatomy. I think that's a very important aspect. We're no longer, it's advisable that instead of just doing a stress test and saying, okay, this patient has ischemia, and so therefore we can treat them medically, that we are actually defining their anatomy and actually ruling out any left main disease. And then when we look at the secondary outcomes for ischemia, consistent with the primary outcome, that we did not see any changes in death from cardiovascular causes or MI with medical therapy versus invasive strategy. Death from any cause also similar, as well as myocardial infarction, recognizing that the peri-procedural MIs increased the MI in the invasive strategy initially, and then in the conservative strategy later on, that we were finding that we had actually an increase in spontaneous MIs, but the overall MI difference was not significant. So in a follow-up study, I think this is relevant and important. So death from cardiovascular causes, as I mentioned, not different between the conservative and the invasive strategy in ischemia, but the death from from non-cardiovascular causes was actually higher in the invasive arm than the conservative arm. And I think that this is something that we should think about and try to understand a little bit better, why we had actually a doubling in malignancy between patients that were actually going through an invasive strategy, and actually the more angiograms they got and the more exposure to radiation, these patients actually had a higher risk of malignancy, although, biologically, how would that have happened in such a short period of time? It's a little bit unclear. And then the increase in risk of death from unknown causes in the conservative strategy is also somewhat suspect. Perhaps those were actually cardiovascular deaths, but was unable to be determined. So the takeaway is that I do think that in patients who would have met criteria for these trials, and that clinicians would have been willing to consent, enroll, and randomize in the clinical trials of revascularization versus optimal medical therapy, that current optimal medical therapy does work well for the outcomes and the time periods that are studied. Understanding also that we have about 20% crossover from patients who are treated conservatively into an invasive arm. But it is important also to recognize, and I would acknowledge, that revascularization does improve anginal symptoms to a greater degree than optimal medical therapy, particularly amongst patients with more frequent angina. So I think we have a lot of things to kind of think about in our field. So what is the problem? I mean, why? I guess a question in general is, do we think that these studies have actually changed practice? And I think that initially after ischemia, from what I have observed, it seemed like for a while we were being maybe more conservative, and now I feel like we're just kind of getting back to what we were doing honestly before ischemia was published. And I think some of it has to do with concern about making the best decision for our patients. There was some crossover. What was the quality of the PCI in the trials? It would be great to see the individual site level data. Medical legal concerns. If you decide you'd want to treat your patient conservatively and then they have an MI, does that mean that we should have paid more attention to the spontaneous MI aspect of the trials? Is the patients in reality, are they getting the level of intensive medical therapy that the patients got in the trials? Are there still subgroups that might benefit, like patients with a low ejection fraction? And then, I think it is hard to get patients to adhere to these medical and lifestyle changes. If it was easy, everybody would be healthy. So, I guess the big question is, what is the solution to this overall problem? Do we just accept the data that we have and try to work with it, wait for the 10-year results from ischemia, or maybe it's even important to look at longer-term data, like 20-year data. If these patients were in their mid-60s, it might be useful to look even longer than 10 years, since the life expectancy is generally speaking longer than that. Should we do another clinical trial? Should we stop trying to study it? And, the big question is, have these practices or these trials changed our practice? So that's all I have.
Oh, you were really nice, Nadia. I could tell you're a really card-carrying interventional cardiologist wanting to do PCI on everyone. But the truth is that all three speakers did not really tell us what they thought about Revived. You did, Greg, you put it up there. But we can't ignore Revived. Revived was a prospective randomized study that showed no difference between optimal medical management and PCI in that population. So, but all three of you are pretty much would say that, yeah, optimal medical management has gotten a lot better. And believe you me, I'm not convinced that Revived's got it right. So where do we stand? Let's start with you, Mario, and then we're going to go to lunch. And then quick close, because you stand between lunch and these people. Yeah. Press and hold. And we won't talk while you're speaking.
Okay, so remember that even Stitch was neutral at 5 years follow-up, so maybe it's just too early to see a difference between group. Roxana, I do not know. It is important, but it is a single trial, and the single trial never change practice.
Very good. Greg?
First of all, I just want to add, Nadia did a great job, and obviously optimal medical therapy is foundation for all of the three approaches. Not everyone with LV dysfunction needs revascularization. If you've got patients that are on optimal medical therapy that are not having ischemia and not having heart failure, those are patients that we really haven't randomized, that we really don't know the outcomes of. And as you can see, even in the Optimum trial, there's substantial mortality with revascularization in all of these patients. So I think we all took debate positions, right, where we all had to defend our position.
I want to know where you really stand.
There are clearly some patients who are going to do absolutely best with coronary artery bypass graft surgery. Without any doubt, extensive coronary disease, bad LV, but otherwise good surgical candidates, they should absolutely have surgery. And there's some patients who don't need medical therapy or are too high risk for revascularization, who are going to do best with medical therapy. And I think the majority will do good with PCI.
All right, great. Nadia, last word.
So, I agree with all of that. And I think that this is a little bit of a cop-out, but I think we just have to look at every patient individually. If you have a young person who has focal disease and, either they want or they don't want surgery, I feel like we just kind of have to look at every person individually. And I think it also depends on the center that you're at. If you're at a place that does an amazing job with bypass surgery and you think the patient could be a candidate and you think that that's going to give the patient a better longer-term outcome, then I feel like that's a great option. And if the patient is at a place where you are not confident and, then in one way or another, then, perhaps that needs to be taken into consideration as well.